Good evening to everybody, ladies and gentlemen. It's a pleasure to be back again on another CME organized by the CPD Committee of the College of General Practitioners of Sri Lanka. I am Dr. Ajay Jayasilan and I will be your moderator today. It's, I guess, a very, very apt and trendy topic today. Obviously, this is, I think, one of the most important aspects. Uh, Even though the topic says obesity in women, I know that all of us will agree that it's equivalently important in both the sexes. But today, the topic will be obesity in women, right? And basically, which is a challenging epidemic. So to do these honors, we have a very esteemed speaker, right, and a personality in front of us. Basically, this time from overseas. It's a pleasure to invite and introduce Dr. Firdous Jahan. She's the professor, head of Department of Family Medicine, College of Medicine and Health Sciences, National University, Sohar, Oman. She had an MBBS from the same university and also has a lot of qualifications as MCPS, FCPS from the College of Physicians and Surgeons of Pakistan, associated with the Aga Khan University Hospital, Karachi, Pakistan. As faculty since 2002 till 2011, and also as a consultant family physician and have been contributing extensively to education, research, and service, etc. She joined the College of Medicine, Oman Medical College in 2011 till date, currently working as a professor and chair of family medicine. She's a dedicated educator with more than 30 years of service in healthcare. At its institutional level, she's been the member of several important committees concerning professional development, research, and curriculum. Chaired Research and Innovation Committee of Medical College for more than 4 years. Her research special interest is in medical education, also non-communicable diseases and public health issues. She's published more than 91 research articles in peer-reviewed journals. Also, other scholarly activities include abstract presentation in national and international conferences. She's received awards and recognitions, many, I suppose, but just to bring about few. First Research Forum Award by Ministry of Health, Oman, on 6th December 2015. And WHO Professional Award in Health Science from Government of Pakistan on 3rd June 2016 at the Governor's House in Karachi, Pakistan. Also, Communication, Motivation, Continuation Research Forum Award, North Batina Ministry of Health, Oman on 13th May 2018. And also Best Research Presentation Award at National University Research, also on Research Day. She has a very, very long introduction and a lot of facts to fill, but I think since time concern, and I'm sure I have filled in most of the important stuff, it's with great pleasure that I invite you, Dr. Firdous Jahan, to do this presentation.
Okay, thank you very much, Dr. Ajay, for this nice and very refreshing introduction. Thank you so much. I will just put my presentation on slideshow now, okay? And good evening, everyone, and especially our colleague from Sri Lanka. I have been to Sri Lanka in May 2023 for this conference, Family Medicine Conference, and I really thoroughly enjoyed that conference and Sri Lanka and Colombo. So my designation is I'm a family physician and I'm working in Oman as a head of the department in family medicine, National University. Today's topic is basically the problem which we are focusing mainly for women. And these are the objectives of my presentation. I'm going to have an overview of the obesity and morbidity in women, especially, and causes and management. And at the end of the presentation, we'll take some questions. So you can write your question in the chat box and we'll take one by one. So for the introduction, that what is actually obesity and how important is to recognize and manage obesity to prevent some of the complication later on. It is not only the problem of one area or one continent. It is in the developed countries or underdeveloped countries. So there must be multiple reasons behind that. WHO defines obesity if the body mass index of 30 kilogram per meter square or more. So this is the definition universally accepted. Now, obesity has reached its epidemic proportion globally, with at least 2.8 million people they are dying each year because of obesity or overweight problem and the complication. It's a complex disease, uh, and it defined by excessive fat deposit that can impair the health. So there are definitions for different regions, for different parameters, but generally it is accepted by WHO criteria that 25 or more is overweight and more than 30 is obesity. Now, if you can see the prevalence of worldwide, the obesity has been doubled since 1980. So you can imagine that how frequently and how disastrous is this epidemic is going. In 2014, more than 1.9 billion adults are overweight, over 600 million were obese. Now come to the GCC states, and GCC named the most obese population, and the highest one is in Kuwait, which is 48%. Saudi Arabia is the number two in GCC, 44%, and UAE 42%, and Qatar 32%, and Bahrain 38%, Lebanon 27%, and Oman is the least in the obesity. It's 22.1% up till now, published article. But in the data of Ministry of Health, it is around 32 to 33% now. So you will see the published data soon. The global prevalence of overweight is 3.3%. However, the Arab countries showed the highest prevalence of overweight with a rate of range from 3.1 to 9%. And 26% of non-pregnant women aged 20 to 39, they are overweight and 29% are obese. So now you can see the prevalence worldwide and mainly in the regional areas, and you can see that how it is becoming an epidemic uh, very soon. Now, if we talk about obesity and women health, there's a risk of cardiovascular disease. Obesity is one of the risk factors. And it is one of the risk factors for diabetes also, for hypertension also, for musculoskeletal disorders, for fertility. So the women who are obese, they have a fertility problem. And some of the cancers, they are actually very high prevalent in these women, like endometrial cancer, ovarian cancer, breast cancer, or cervical cancer. And there's a chances of premature death in these women. And it is a independent risk factor for coronary artery disease, that is a modifiable risk factor in prevention of the coronary artery disease. Now, how it is going to be epidemic. The very rapid urbanization, as you know, in the developed countries, or even in the underdeveloped countries, or in developing countries, this urbanization has, improved your living condition, and especially in Arab countries, they have a very rapid urbanization. Now, the use of unhealthy diet or fast food and reduced physical activity. These two components are going together. And one more component in these countries are the cultural barrier that appears to affect women more, like managing their diet in pregnancy and the postpartum period, the lack of communal exercise facilities for women. So they cannot walk freely outside. So these are the restrictions. And the biggest one is the diet and lack of activity. Now, the stress-related eating with weight gain is a very normal phenomena. Like if you are under stress, you start doing binge eating, like you eat very frequently whatever is available around you. And the lifestyle choices. Now, the lifestyle choices, sometimes it is not in your hands, but females, they have very limited access to sporting exercise activities. Nowadays, there are gyms for females only, or there are easy access female gyms also available. Now, women in the developed world commonly they employ cooks and maids, so they have a very luxurious lifestyle, sedentary lifestyle with TV and social media being the main leisure activity, and they're very comfortable in their lifestyle. The other thing is that there's a lack of information about healthy eating, and there's a lack of motivation to eat healthy diet, and not having time to prepare or eat healthy food, and lack of time to do the physical activity. These are the some of the barriers you can say that these are causing the additional factors. Now, whereas many of the families they have very high income, and the world is going towards more and more advanced technology and more income, so they can afford all these things. The rich fat diet and carbohydrate diet and processed diet is another problem. Like if you are not cooking at home, then you can buy food, and you know what you are buying from the restaurants or from the mall. It's high fat, saturated fat. Now, the last part, which is the puberty, pregnancy, and menopause, these are the main area where we are going to focus on. That these are the trigger area, the puberty, pregnancy, and menopause. Now, if you see that how there's a mismatch between the energy balance. So if you want to see that why I'm getting more and more fat in my body, there are two things you should understand. One is the energy balance, which is that the energy you take and then the energy you lose. So the energy balance is depends on your metabolic rate, the basal metabolic rate, your appetite, your diet, and your portion size in the diet, and physical activity. Sometimes there are some drugs which can uh, just facilitate those fat deposition or some neuroendocrine disorders. But mainly the energy balance is the problem. Now come to the next part, that what is the energy balance? Energy balance means that your intake and your expenditure, that how much you take and how much you expend. Now this phenomena is very simple. Now if you are taking more and your expenditure is less, then you are going to deposit fat. Okay, so how would you know that I'm depositing more and more? Okay, before that, you should understand that why we are concerned about obesity. We are concerned because there are many diseases. They are associated, and many diseases are prevalent in obese patients. So there are diseases listed in the slide like diabetes mellitus, hypothyroidism, polycystic ovary syndrome, some of the drugs, steroid or oral contraceptives, family history of obesity, anxiety and depression, hypertension, hyperlipidemia, Cushing syndrome, osteoarthritis, backache, and genetically predisposed like leptin deficiency or leptin resistance. Now, obesity may be associated with these conditions. So, if you find any disease, then you have to see the patient's BMI, whether there is an additional risk factor in this patient or not. Now, women are at increased risk of having diabetes. If they're obese, they have a high risk for diabetes, osteoarthritis, hyperlipidemia, PCOS, sleep apnea, gallstone, coronary heart disease, hypertension, cancer, especially colon, uterine, and gallbladder, and depression, fatty liver disease, and dyslipidemia. So, these lists, you can just see that how much a woman is at risk. So it is not only women. I'm talking about the other gender also, but we are at the moment we are focusing on women and the triggers for women obesity. Now, these are the risk factors. So, if somebody is obese, then you need to talk to the patient in the management about those risk factors. That if you control your weight, you can reduce these risk factors in your life. Now, come to the trigger. The first trigger is the pre-pregnancy obesity, or at the puberty, you can say. At the puberty, there's a changes in the hormone in the body, and the hormones and the dietary pattern and the physical activity all together, if the young girl is not taken care of, then the weight is very easily put on. Now, the development of many pregnancy related complications like pregnancy-induced hypertension, preeclampsia, gestational diabetes, more C-sections, and neonatal death seen in obesity. Maternal obesity is associated with decreased intention to breastfeed and decreased duration of the breastfeed. And there is a strong association between the obesity and type 2 diabetes. What we call as type 2 diabetes, mellitus, and obesity together is diabesity. So this terminology is used when there is a diabetes and obesity together. Now, see, after puberty, the pregnancy. During pregnancy, there is weight gain, and the average weight gain is 12 kg. Now, after the pregnancy, if the lady did not go back to the normal, which is usually not 100%, but some of the weight is remaining. So in each pregnancy, some of the weight is remaining behind, and that leads to obesity. Now, during pregnancy, if somebody has the implication of obesity, just think about gestational diabetes, gestational hypertension, preeclampsia, more cesarean deliveries, fetal macrosomia, late fetal death, early neonatal death, and thromboembolic diseases and birth defects. So these are the complications during the pregnancy associated with obesity. In the postpartum, weight retention, as I told you, the weight retention is a big problem. That if you don't care about your weight and your diet and your physical activity, there's a very easy obesity after the delivery and anemia. Now, how to go about? So the screening is usually done. Usually the age is 35 to 40 years in different countries, different age group, but usually 35 to 40, the first screening is done. But if there's a risk factors in the family, then the early screening can be done. So the BMI is calculated for the major height and weight. And in South Asia, there's a special consideration about the norm and overweight and obesity as compared to international criteria. So in South Asia, the normal is from 18 to 22.9, and overweight is 23 to 24.9, and obesity more than 25. While in international parameters, the normal is 18.5 till 24.9, and overweight is 25 to 29.9, and obesity is more than 30. So these are the screening criteria, and you can tell your patient that you are overweight or you are obese now, and you should take care of your BMI from now onward. So one more thing which we take care of is the waist circumference, because it is again a parameter for the obesity measurement. In male, it should be less than 102 centimeter, and in female, less than 88 centimeter. Now, at this point, we know there's no single etiology and there's no single phenomena which is causing obesity. So there are multiple factors and there are multiple uh, levels of risk factor and triggers in women, especially like puberty, pregnancy, postpartum period, menopause. So these are the very important four areas where we should look at our patient. And as a general practitioner or a family medicine doctor, you should counsel them uh, when they are not obese. This is the best part of our counseling. When there is no disease, you can counsel about the disease, how to prevent the disease, and how to monitor your uh, the best kind of health and health promotion. Now, the strategies for the management, there are four devices you can see now in the slide. One is dietary. The second is physical activity. And the third one, maybe you can say it's medication. But the most important one is the behavioral lifestyle changes. Okay, so I put behavioral lifestyle changes on the top, not the dietary. And you can see how it is going to affect you and your patient's family. If you can counsel them in a positive way, that obesity, you tell them the success story and the safety about the normal weight. That if you are with the normal weight and if you gain weight, then there's a chance that you can reduce the weight. But if you are obese, then it's very difficult to reduce weight. While you are counseling, also you must address the constraint. Sometimes it's a cultural, sometimes it's familial, sometimes it is financial or any other constraint. So ask them, if you're not doing physical activity, why? Why not? If you're not having uh, a balanced diet in your life, why? Can you change it? And this counseling should be very realistic and very specific. Okay, so do not tell the patient that if you are obese, then you will get heart attack. This is a negative motivation. So if you say, if you reduce your weight, you look pretty, you look very beautiful. So that is positive motivation. So tell them the success and the safety. And your counseling should be with the small steps. Don't give them a big dietary chart or physical activity chart. And you can do this small step in subsequent visit. So the patient can recall what they are eating, the physical activity at home, and based on that, you can make the plan for future. Now, what is a balanced diet? The first thing you should understand, the balanced diet is the diet which everyone should take, whether the patient is diabetic, whether the patient is hypertensive, patient is obese, patient has some problem or no problem. So the balanced diet is actually a diet which contains everything in a good proportion or in appropriate proportion. So, based on the basic knowledge that 50 to 60% carbohydrate and 12 to 20% protein and less than 30% fat, this is the calculation we have. But in practical situation, when you are talking to your patient, you need to talk to the patient in terms of the quality of the food and the quantity of the food. So the complex carbohydrate like brown bread, or brown rice, or cereal, or fruits and vegetable, they have complex carbohydrate. Proteins, the good protein is meat, fish, cheese, egg, milk, pulses, beans, and vegetable. And for fat, uh, again, oil, cream, butter, these are sources of fat. Now you have to combine all these in a proportion that gives you a balanced diet. Okay, so the balanced diet is for all. So I'm not uh, saying that the diabetic should take this and non-diabetic should take this. But the manipulation in the diet is done only when there's a requirement. Like if somebody is diabetic, we say take 5 portions of fruits and vegetables. So why not you and me? We are not diabetic, but we can take 5 portions of fruits and vegetables, which is good for health, and avoid red meat because it contains more saturated fat. But fish and chicken is good. So why not fish and chicken? Okay. So this manipulation is done while you are counseling your patient. Okay. And see her problem, that what is the concern and what is the constraint in this patient. There are certain micronutrients which you need every day, like the vitamins, vitamin A, C, K, folic acid, iron, calcium, and fibers and water. So these are all required in a balanced diet. So if you want to make a portion for a balanced diet, ask the patient to do it by herself, what she is eating. If she is eating more carbohydrate, just reduce the carbohydrate. If she is eating a lot of protein or a lot of fat, then you reduce the fat and protein and balance the carbohydrate. So it depends what your patient is taking. Now, there are the micronutrients, they are very important, like iron. Iron is very important. Iron is very high content in the red meat and green leafy vegetable, in liver and organic meat, chickpeas, legumes, dates, and nuts. And vitamin C increases the absorption. Calcium is in milk, yogurt, cheese, green leafy vegetable. Now, you have to choose from this list that what is suitable for your patient. Suppose your patient has dyslipidemia or obese, or she has some other risk factor. So you would not advise red meat. Okay, so you would advise white meat with green leafy vegetables or chickpeas or legumes or dates. They have good source of iron. Similarly, calcium. If the patient says that I cannot take milk, I cannot take cheese, so the yogurt is the best kind of thing to take, or green leafy vegetable. So you have to give them choices, that these are the choices available for you. Besides diet, there's one more phenomena, which is the walking, the exercise, the physical activity. And we don't understand that how important is physical activity in our life, not only in the adulthood, but in the childhood. Because whatever is the habit you make during your childhood, it stays. So if your child at younger age group, near puberty or at puberty, has an exercise habit, he or she will continue that. So American Diabetic Association guideline says that every man and woman should walk 30 minutes brisk walking every day, 5 days a week. But you can start like 20 minutes or 15 minutes per day, and you can build on 30 minutes. Okay. So it's not necessary that you start all of a sudden 30 minutes. Okay. Now, this is the problem. The problem is the willingness. When you are willing to do it and you are making your habit, then you can do it. So the personal feeling and the personal uh, attitude or a behavior actually is the problem. It's not that the availability. You can find out the ways. So the doctor asked this woman to spend 1 hour. So she's sleeping on treadmill. Okay. So don't do that. Okay. So you have to active, make yourself active. Your body should be active. Now the behavioral modification is the crux and is the bottom line of your management plan. Because sometimes your patients say, I'm an emotional eater. When I'm sad, I eat. When I'm happy, I eat. When I'm bored, I eat. When I have anxiety and depression, I eat. Okay. So sometimes you have to make some obstacles, like do not put something unhealthy in your fridge or in the cupboard, because when you are bored or you have some anxiety, you immediately you go and you eat, and that resolves your anxiety and depression or your emotional uh, behavior. So sometimes you have to do some uh, more appropriate proactive actions. And food rewards should not be given. Like if you have done something good, so we'll take you for dinner, or we'll give you some, uh, pizzas. So it's like if you change your behavior, your children will change the behavior, and your patient will change their behavior. So it's doctor's behavior is actually contagious to others. So remember this, the lifelong commitment, and you need a periodic reinforcement. So you cannot say that, okay, today counseling is done and I am done with you, and you are going to have, weight reduction in next 3 months. It's not like that. It's a lifelong commitment. Because once you stop doing all these things, which we discussed now, you have the rebound. And the rebound is even bad. So, um, medications, we do not prescribe medication as a GP, but there are certain medications available and they are FDA approved. Like Orlistat is a pancreatic lipase inhibitor. Sibutramine inhibits the uptake of noradrenaline and serotonin, okay, and leptin hormone. But there are some new drugs, GLP-1 RAS. Semaglutide is a potent, long-acting analog that requires once-weekly administration, and that has been shown to reduce energy intake and hunger, and it increases the feeling of satiety. Metformin used for PCOS seems to be reducing the weight. And naltrexone is an opioid antagonist with indication for the treatment of opioid and alcohol dependence patients who are obese. So that inhibits the appetite enhancing and the effects of beta and endorphin caused by cannabinoid 1 receptor activation, decreasing the food craving. Food craving is very, very bad. If you have craving, you need something to eat. Um, and naltrexone reduces craving. Surgical intervention is done if the BMI is more than 40 kilogram per meter square. If the patient is very obese, morbidly obese, and not been successful uh, with the diet, then after exercise, medication, there's a recommendation. If the BMI is more than 40 or BMI more than 35 with obstructive sleep apnea. So the patient can be referred for surgery, for gastroplasty, or gastric bypass to intestine. So these are the last resort for obesity treatment. Now, I have now at the end of my presentation in conclusion that obesity is becoming more and more prevalent and has a wide-ranging effects on a variety of women's health issues. The change in dietary habit and lack of physical activity are the main factors responsible for the high prevalence of obesity. And clinicians should counsel all women about the broad negative effect of obesity and the importance of controlling weight. Intervention programs are needed to combat obesity. The socio-cultural barriers to practicing physical activity, the mass media, the TV, and other social media organizations should provide sound and reliable information on the treatment of obesity and the hazards related to obesity. The policy initiative may increase the convenience of purchasing healthy foods and create safe neighborhood venues for walking and leisure activities. So weight management for obesity, if you ask the physician, so they should say it's a journey. You cannot say that it's the destination. So this is the parking area. No, it's the destination. It's not a destination. So it is going on and on and on throughout your life. So once the patient comes and you have, I'm sure all general practitioners, they have all kinds of patient like children, adolescent, adult, postmenopausal. So any woman at any age group, any girl coming to you, you just give them something regarding the obesity and its hazards and what are the triggers in obesity. It's important to inform them that during puberty, during pregnancy, after postpartum, at menopause, you will gain weight. Okay, so be careful and try to reduce your weight and be at your level of BMI. So this picture, just see the picture and you will understand that there are two extremes of thing. People who have everything and they are obese. People who don't have anything and they are asking for privilege. And if you feel that this counseling is better, then try to counsel your patient uh, as soon as you get your patient. And if you make them understand, they will do it. Because if you don't counsel them, no matter you give the medication or the advices or the dietary uh, uh, brochure, they will not follow. So it's the change the mind of somebody who can uh, understand what is the importance of uh, the weight management. Thank you very much. And I hope that you have some questions for me.
Right. Thank you very
Okay.
much, Dr. Firdous, for that very, I think, elaborate, enlightening, and basically factful presentation, which actually opened all of our eyes. Uh, as I also told in the introduction, as much as it's very important, the fact of obesity in women, it goes in hand for men. And I think you did mention that also. So I guess it was I think a very good presentation, and you had covered everything well. It was a treat for all of us. Thank you very much. How long? Okay, so there are some questions on
Yes.
the chat box. I will read it, madam, and then you can answer. Right. So first is
I
it's
can I can read the questions, no
right.
problem.
Okay, fine,
No
fine.
problem.
Then you read it. Okay, right.
Okay, there's a question. Metformin dose for obesity now long if diabetes, obesity also, it is helpful. Actually, metformin is not used for obesity. It is used for polycystic ovarian syndrome and diabetes. And uh, people notice that those patients who are on metformin, they actually reduce weight because the carbohydrate absorption is reduced in those patients. So this and the distribution of the carbohydrate and the insulin sensitivity increases. So this is actually is not used alone. But if you have a doubt of like pre-diabetic or obesity and somebody has PCO and obesity, you can use metformin as a first line drug. Yes. Okay. Semaglutide is given for weight loss. It is not a credential for GP, so you need to go to a specialist for this drug. Although it is FDA approved, but you need to go for prescription from a specialist. So the internal medicine or a surgeon can prescribe this medication, and the minimum is like 3 to 6 months, and then you can continue as your doctor's prescription is given to you. Okay. Okay. Yes. The evidence is there. Weight reduction using these medications. Yes, and there are published papers. If you can open my there's a very good paper on using these drugs, but the long-term effect of these drugs, we don't know. Maybe we have to wait for a long time to see at least maybe 20 years to see the after effect of the medicine. Yes, PCOs are a very, the best drug is the metformin for PCOs. And that has a very, dual activity. Like it increases the insulin sensitivity, it reduces the carbohydrate absorption. So it's really good for PCOs. And obesity is a problem in PCO. But remember this, that once you are prescribing a medication, the lifestyle modification and the behavioral modification is the topmost priority for a general practitioner. These medications are number two. So if somebody wants to reduce weight and you are counseling this patient that you need to reduce your weight, but change your mindset, then they can reduce the uh, weight. Otherwise, if you prescribe medication, once they stop the medication, maybe there's a rebound. But medication with a lifestyle modification is long lasting. Okay, now if somebody has PCOS and the treatment is going on and there are some advanced treatment is available, so those patients should be referred to gynecologist for the advanced treatment. And there are certain surgical treatment is also going on now for PCOS, not only medication. But remember, and believe me, that lifestyle modification is the first step even in the PCO. So you have, the egg maturation happens once you start walking. So if you are walking 30 minutes per day, within 3 months, there is a maturation of the egg as seen on ultrasound. So it's very good. And you can try this first before you refer your patient to a gynecologist. And you can start metformin. Yes. Okay. The best kind of surgical treatment is again it's a surgeon's uh, decision, but gastroplasty and bypass surgery is usually done, is commonly done, and that has less side effect. But every surgery has a side effect. But remember that the morbid obesity needs surgical treatment, not the usual one. More than 40 or more than 35.
Okay, madam. Yeah, so thank you very much. I think you have answered most of the questions and given us in brief, very specifically, points. And I truly liked. It was very simple and very to the point. And basically, you gave us some take-home messages. I think which is very important.
Yes.
Which at the end of the day, ma'am, that's the main thing that sticks to all of us. And I think the last summarizing of those few points were very good take home messages. Also, I like the way you stressed on the modification of lifestyle. I think that is something now that is stressed. And I think that was something that you brought in a few times. Any other questions that anybody wants to like ask? We can give you a few more minutes. There is time. There is time. So we can entertain a few more questions. Anybody who wants to unmute and ask? I think the questions on the chat box. Could you please share these presentations to those who have registered? Ma'am, you will be able to share this. It is in their requested. Yeah, no problem.
Yes, no problem. You have my email address and you can share the presentation. I have already sent to you and to doctor. And if you have any question, because the most important thing in our general practice and in family practice is that the patient they are keep coming for many problems or even without problem, they keep coming. So the health promotion is our duty. So remember that not only you are treating one patient, you are treating the whole family, the family behind this patient. So don't jump on medications or don't jump on hi-fi investigation. Just try to understand that the patient should be doing these things. And that is the main focus of a general practitioner, that without medication, how can I help my patient? Medication is not the answer for everything. It's like the healthy lifestyle and the healthy balanced diet. And even I have seen many doctors, they don't understand what is balanced diet. They keep on, eating one thing every time. So you should understand as a doctors, the doctors community, that what is a balanced diet, what is a healthy lifestyle. And then believe me, if you are living a healthy lifestyle, your patient will follow you because your patient is looking at you, that how you live and how you behave. So it's all like, the whole package, your emotional stress, your anxiety, your lifestyle, your balanced diet, your physical activity, all in one package. So it is not like something different you are doing. You are doing in one go everything. So is there any other?
Yeah. Any other questions you all have?
Yes,
Ma'am,
sure.
research opportunity. Yeah.
Yes, sure, sure. Absolutely, absolutely. In the type of patient here is different from your side, from your country. And the curriculum is almost, I think, curriculum is same. There's no change in the curriculum. But the brought up and now you can see in most of the uh, GCC countries, especially, and Western countries, they have everything done by others, so they don't do anything. And that is the reason that they're putting a lot of weight and a lot of problems. If you want to do some research on medical education or any non-communicable disease, yes, why not? Why not? Dr. Ajay will
Yes.
share the email address and you can contact me if you want to do something like some data collection or some combined collaboration. Yes, it is possible.
Sure, sure. Thank you, madam. Uh, yeah. So presentation. So we'll organize that sharing of the presentation. Man, did you share it on to me? I not checked it, or to the email? Is it email on the
You can share on WhatsApp. I have sent you on WhatsApp.
right?
You can
Okay.
share it on email. Yeah, you
Yeah,
can
yeah,
share
right.
it.
Okay, I will then get that sorted to the
And
college and let them
yes,
circulate it. I'll get it sorted.
and please, and
Yeah.
one more thing, please ask your participants that what topics they want update, because there are many topics they may have, they are interested to learn about the updates. So we update the topic and we can do the CMEs like this. No problem at all.
So just to tell everybody, what I will do is I will share this to the office, right? Individually to the emails will be a problem. So what the best will be, I will share this presentation to the office, and I will discuss with them so that it can be obviously shared with madam's permission, who is already been granted. That they can send it to the email addresses from the office. That will be more practical, I think. So we'll try to organize that because the office will have the registrations email. Right. Okay. So finally, before we close, any other final sort of comments, because we still have a bit of time. Anybody has any other things you want to share? Thank you for your comments. I think obviously, madam, it was a very short and sweet. So that was the basic point. I have a hand up going. You can unmute. I thought I saw a hand which was up. You can unmute and talk. Do you want to ask a question?
Hello, miss. Are you listening me?
Yes.
Yes,
You have to
please.
be a bit
Thank you,
loud.
sir, madam, for your presentation. It is very informative session indeed. But I have some queries regarding the fully funded scholarship at your research group. Especially, I am looking for some opportunities related to obesity and GIT group, related group. Could you please have any opportunity in your group so that I can apply and do
Actually,
some research?
yes, you can do. it's like we are practicing in primary care. So if you just tell me what kind of research you are up to, so I can advise you that which area and which doctor is doing that kind of research. What kind of research you want to do is on patient data.
Yeah.
Actually, actually, Miss, my area of interest is uh, neuroscience and how obesity is related with neurological disorder and overall its impact on our body.
Okay. So
Uh,
you want to do, okay, okay,
Second question is that if there is any drug discovery group, I mean, is there any group who is working on drug discovery, developing new molecules? And I want to also part of this group because these two areas where I have keen interest. So it would
okay.
be great news for me that
Uh,
I will learn something and work for the humanity, especially in
in,
those countries
okay,
who are not so developed or
okay.
underdeveloped countries.
Yeah, that's a very good thought and good idea. I don't know about the manufacturing of drugs and related to drugs, but yes, for obesity and neurological uh, implication or neurological complication or related to obesity, something, yes, it is a doable thing. Yes, yes, why not? So send me your proposal. Okay, so if it is doable, because we have to go through the ethics committee in our college and then Ministry of Health, so we can do that. You just send me the proposal or at least some objectives of your research and what type of patients you need. Uh, it is a doable thing.
Right. Okay, madam. Then I think one final call for questions. I think, yeah, the final few minutes. Thank you very much for all the comments. I think ma'am is also saying all the comments. So I think there's been a very good session because people have really liked it. So thank you very much, ma'am. So I think that's fine. I think we have got
You're welcome.
yeah, quite a lot of questions in. So finally, thank you very much, madam. For it was a pleasure knowing you, and basically, you brought in a very, I think, a large topic, concised, very sweetly into a small, way where all of us can practically take home. And I think we got it enlightened. So thank you very much for spending your valuable time and hope to see you soon, ma'am. And hope to see you soon in Sri Lanka. Thank you, madam. Take
Yes,
care.
yes, yes, yes. I love Sri Lanka. I have been to
That's
Colombo
nice.
in May,
That's nice.
and we really enjoyed there.
That's
And
nice.
the hospitality and the people there, the
That's
weather.
that's
It
nice.
was very hot, but it was good. Good hot
And
and
yes,
rainy
and we do
season.
all have a lot of Sri Lankan doctors and in other professions
Yes,
in Oman. So
yes,
I guess
yes,
you must be
yes,
meeting, yeah, a lot of people are there.
yes,
So I
yes,
think
yes. Lot
so
of
they
people
do
here.
tell the
Yes,
same thing about you all. Everybody likes the place. So so I think
yes.
it's a win-win
And
for both
Oman
of
is a beautiful country, and I
yes,
hope that some of you can visit to us.
yes,
And
yes.
the people are very good,
I
and
have heard.
weather is very hot, but the living condition and the primary care is very strong. So I
Yes.
advise you, if you have time, sometime you can visit to our primary
Sure.
care.
Thank you.
Okay.
Okay, ma'am. So we
Thank you
will
so much.
take your leave. Thank you very much. Thank you very much. Yeah. Good night.
Okay. Thanks a
Okay.
lot. Thank you.
Welcome.
Thank
Thank you.
you.
Good night. Bye.